my dearest viewers, welcome back to yet another episode of EM Rapid 2022. In this video, we'll be discussing about paracetamol poisoning. Now, as we all know, paracetamol is one of the most common over-the-counter available drug, and it's otherwise called as acetaminophen. The chemical name as N-acetyl P-aminophenol. Now, because it is so easily available to people, it's also one of the most common drug that has a toxic exposures reported to poison center, and it is available as a sole agent, or it can also be combined with a variety of other medications prepared in many different forms, such as tablets, capsules, shells, and liquids. Now, when we talk about the dosing of paracetamol, the recommended maximum total daily dose of oral acetaminophen is up to 3,900 milligrams in adults, which roughly accounts to up to 4 grams in adults. Now, for children, it's as per the body weight, and the recommended dose will be 10 to 15 milligram per kg, which is given every 4 to 6 hours as needed, with a maximum daily dose of 75 milligram per kg, or you could give up to 5 such doses over a period of 24 hours. Now, patients with insufficient glutathione stores, like those with the patients with AIDS or the alcoholics, and those patients with induced cytochrome P450 enzymatic activity, like the patients who are on anti-epileptics or anti-tubercular drugs, they will be at a greater risk, or they will be more susceptible to develop paracetamol poisoning induced hepatotoxicity. As to why those patients are more prone, we will understand that in our subsequent slides when we read about metabolism. So for now, let's just know that these category of people are more prone to develop acetaminophen-induced hepatotoxicity. Now, when we talk about the pharmacological aspect of it, acetaminophen gets rapidly absorbed from the GI tract, and peak serum concentrations will be reached within 30 minutes to 2 hours. Now, this I'm talking about when it is consumed orally. Now, talking more about the pharmacological part of acetaminophen, I would like to mention that the bioavailability of paracetamol is nearly 100%, of which 20% will be bound to the serum proteins. Now, volume of distribution will be about 0.85 liter per kg, and half-life, or rather the elimination half-life, will take about 2.5 hours. Now, for the antipyretic effect of acetaminophen to kick in the body, its therapeutic concentration should be somewhere between 10 to 20 microgram per ml. So that would be about the oral dosing. Now, when we talk about the IV dosing, it was approved in the year 2010 for adults and children above the age of 2 years. Now, the recommended dosing for those weighing above 50 kg is 650 milligram every 4 hours, or 1 gram every 6 hours, with a maximum total daily dose of about 4 grams. Now, for those who weigh less than 50 kgs, the recommended dose would be about 12.5 milligram per kg every 4 hours, or 15 milligram per kg every 6 hours, with a maximum individual dose of about 750 milligram, with a total daily dose of about 75 milligram per kg, or 3,750 milligrams. That is 4 grams total daily dose for those above 50 kgs, and 3.7 or 250 milligrams less, 3,750 milligrams for those who weigh less than 50 kgs. Now, for peak concentration, it will, for the drug to have its peak effect, it'll occur at the end of 15-minute infusion period. So this would be the IV dosing. Say 4 gram would be the maximum, or rather recommended daily dosing for a patient to avoid poisoning. To understand how paracetamol poisoning causes hepatotoxicity, it becomes essential for us to understand how paracetamol gets metabolized in the body. So in therapeutic amounts, acetaminophen gets primarily metabolized by the liver, and it's majorly through sulfation and glucouronidation, and less than 5% undergoes excretion or elimination through the kidneys. Now, in that, also a small percentage of it gets oxidized by the cytochrome P450 system to a reactive metabolite which is called as NAPK, N-acetyl P-benzoquinoamine. Now, NAPKI is again quickly detoxified by the hepatic glutathione to a non-toxic acetoaminophene mercapturate compound, which is now excreted by the kidneys. Now, what happens? So basically, to quickly sum it up, you have acetaminophen being primarily metabolized by the liver through sulfation and through glucouronidation. A small fragment of it or percentage of it gets excreted through the kidneys. Now, also another small percentage will get oxidized by the cytochrome P450 system to a reactive metabolite, that is NAPKI. Now, NAPKI gets detoxified by the hepatic glutathione to a non-toxic acetoaminophene mercapturate compound, which is now eliminated through the kidneys. Now, what happens? Now, all of this happens in therapeutic concentrations. Now, what happens is whenever there is a acetaminophen overdose, more and more of NAPKI gets formed. That's the reactive metabolite. But the glutathione reserve of the liver gets depleted. Because good amount gets metabolized through glucouronidation and sulfation, and when that gets saturated, a larger portion of acetaminophen will get oxidized by the cytochrome P450 system to a reactive metabolite, that is NAPKI. Now, when more and more of NAPKI gets produced in the body, it will deplete the intracellular glutathione reserve. So when glutathione decreases to less than 30% of normal, NAPKI now starts to bind to other hepatic macromolecules and hepatic necrosis occurs. Now when hepatic injury, hepatic injury will occur early, that is within 12 hours of exposure. Glutathione decreases to 30% of normal, NAPKI gets bound to other hepatic macromolecules, and that will cause hepatic necrosis and very soon hepatic injury, that is within 12 hours of exposure, hepatic injury starts to develop. Now, cytochrome P450 is majorly concentrated within hepatocytes, that is surrounding the terminal hepatic vein, and it is least concentrated within the hepatocytes that is surrounding the portal triad, which is why the pattern of hepatic injury is centrilobular. So you will get to see centrilobular necrosis in paracetamol overdose. Now, hepatocyte damage will typically cause cell lysis that will release more and more of hepatic enzymes like SGOT, SGPT, and NAPKI hepatic protein will then get thrown into the system or released into the system, which will be detected. So when we're talking about the clinical features of acetaminophen toxicity, it is non-specific and delayed in onset, and it occurs in stages. So we understand acetaminophen toxicity in 4 stages, wherein stage 1 includes, within first 24 hours. So in that, patient will present with anorexia, nausea, vomiting, and just generalized tiredness. And when we take in the lab investigations, all we see is a hypokalemia. Now, stage 2 is from second day to up until third day. Now, in this, the first symptoms that developed, within 24 hours, the one, anorexia, nausea, vomiting. Now, these symptoms will improve, but the patient will have new onset of abdominal pain and hepatic tenderness. Now, this is the beginning of hepatic injury. As we discussed during the metabolism of acetaminophen in the body, hepatic injury occurs within 12 hours of exposure. So for it to reach its peak and develop or elicit signs of hepatic tenderness, it takes about 2 to 3 days. And at this junction, if we take lab investigations, we will end up finding that SGOT, SGPT levels are elevated in the body along with bilirubin levels, basically abnormal LFT with prolonged PT. If at all the hepatic injury has been severe, we even end up seeing coagulopathy in the form of elevated PTINR. Now, after the stage 2, it's stage 3, that is from day 3rd to day 4th, wherein you have recurrence of the symptoms that we first experienced, or rather that we first saw during the first stage, that is within 24 hours. You will have again recurrence of anorexia, nausea, vomiting, but along with these symptoms there will be development of encephalopathy, anuria, and jaundice. Now this is the peak time wherein the paracetamol toxicity will blow out of, will blow up, and lab investigations will show hepatic failure, metabolic acidosis, coagulopathy, renal failure, pancreatitis, that is, all the complications of acetaminophen toxicity will peak, that is from day 3 to day 4, and this is the most dangerous stage wherein patient can even end up dying if it is not treated promptly and early. Now, after when this stage passes, it is the 4th stage, that is after day 5, patient will improve clinically and patient will recover by 7th to 8th day, or like if at all we have dealt with acetaminophen toxicity and prompt management has been provided to this patient can either clinically improve and recover within a week, or patient can deteriorate, go into multi-organ dysfunction, and ultimately die. Now, lab investigations can be, like either when the patient is improving, so you will see all improvement in the lab parameters, or when the patient is clinically deteriorating, lab abnormalities will further increase, or rather will further become more serious. So we study it in 4 stages. Stage 1, that is within 24 hours, where vague symptoms of anorexia, nausea, vomiting is seen. Then the second stage is between day 2 to day 3, wherein there will be improvement in the first stage symptoms, but patient will end up with new onset of abdominal pain and hepatic tenderness. Then this is followed by stage 3, that is between 3rd and 4th day, where patient will worsen. Uh, Patient will end up with hepatic failure. You will have recurrence of the symptoms that we first observed in stage 1. And then this stage will be followed by stage 4, that is after day 5, where patient can either improve or can deteriorate and die. Now, moving on to the diagnosis, once we've understood the metabolism of acetaminophen in the body and we've also dealt with the clinical features, we need to identify, and for identification, first we need to know what is the toxic level in the body. A toxic exposure for anybody more than 6 years of age will be more than 10 grams or 200 milligram per kg as a single ingestion or over a 24-hour period, or it should be more than 6 grams or 150 milligram per kg per 24-hour period for at least 2 consecutive days. For children less than 6 years of age, ingestion of 200 milligram per kg or more of acetaminophen as a single ingestion or over a period of 8 hours, or 150 milligram per kg per 24-hour period for the preceding 48 hours, basically 2 days, is considered to be toxic. Now, once we've understood the metabolism of acetaminophen and we've also studied about the clinical features of paracetamol toxicity, we'll move on to the next entity, that is diagnosis of paracetamol overdose. Now, acetaminophen concentration can actually be charted on something called as a Romack-Matthew nomogram. Now, what we need to know about this nomogram is that it will only apply to acetaminophen concentration, which is obtained after a single exposure, single oral exposure, that too after 4 hours, like 4 hours post ingestion and within 24 hours. So in this 20-hour window period itself, only that acetaminophen concentration can be measured. Anything that is obtained outside this 20-hour window, it cannot be applied on this nomogram. That is, those with chronic or recurrent exposures. So basically, post-ingestion 4 hours to 24-hour window period is when we chart acetaminophen concentration on this nomogram. Which is why it is extremely important for us to send the sample for toxicology reporting to check the paracetamol levels 4 hours post ingestion. So when we chart this, it comprises of there's a nomogram line which will separate the possible toxicity from unlikely toxicity. So we will know the toxicity level of paracetamol in the body post ingestion. So the key points in this is that acetaminophen concentration can be measured on something called as a Rumack-Matthew nomogram, where it is only applicable when it is charted between 4 hours to 24 hours window post ingestion, not applicable when it is when the exposure has been chronic or recurrent. So it's a single oral exposure 4 hours post ingestion within 24 hours, which is why the samples will be sent after 4 hours of ingestion, and there will be a nomogram line which will separate the possible toxicity to the to the level which, wherein you could declare that the patient levels of the paracetamol in the body is not toxic. Now, as we can see, here's a picture of a Rumack-Matthew nomogram, and it is to be charted between a 4 to 24-hour window period post ingestion. Now there are two lines. One is the bold blue line, as we can see, and the other one is a dotted or a broken red line. Now, the acetaminophen concentration, what is measured in the body, is to be charted between this window period, and if the concentration crosses this blue line, we can say that the concentration in the body is enough to cause hepatotoxicity. But if it falls below this broken line, it is, like the levels are not toxic, or rather it won't cause hepatotoxicity. So these are the two lines. One is a blue bold line and the other one is a broken red line. So we recommend treatment if the concentration level crosses or gets above the broken red line. But if it crosses above blue line, we know that there's a possibility that hepatotoxicity can ensue. So far we have understood how paracetamol gets metabolized in the body by the liver, and we've also looked at how the patient with paracetamol toxicity presents to the hospital. We have also looked into the diagnosis part of it, wherein we have charted the measured acetaminophen concentration in the body on a Rumack-Matthew nomogram, and we have seen that the levels have crossed the bold blue line, and we have established the fact that this patient is now is in paracetamol overdose, or rather paracetamol poisoning. So this will bring us to the last entity of it. That is, how are we going to go about this whole thing? How are we going to treat the patient who's presented to us with paracetamol poisoning? So in this, it majorly comprises of two things. One is GI decontamination, and the second is early administration of antidote, that is N-acetylcysteine. And we symptomatically provide treatment for whatever patients, or the clinical features the patient has come up with. We symptomatically and supportively provide care. Now, adequate GI decontamination comprises of early administration of activated charcoal, which is either given orally or it is given through a Ryle's tube, a nasogastric tube. We could also induce emesis by IPAC syrup, but that is not very desirable because it'll delay the administration of oral antidote, that is N-acetylcysteine. But aggressive forms like gastric lavage or whole bowel irrigation is not really necessary, as paracetamol has a very rapid GI tract absorption. And if you remember, it was within 30 minutes to 2 hours, it gets rapidly absorbed, and peak concentration of this drug will be reached in the body, which is why aggressive forms will not be that effective or will not be necessary. So GI decontamination, preferably early administration of activated charcoal, either orally or through NG tube, is what is recommended. And without further delay, we move on to providing, or rather administering, the patient with the antidote, that is N-acetylcysteine, which is the mainstay for both prevention and treatment of acetaminophen toxicity. Now, in early poisoning, that is within 8 hours of ingestion, N-acetylcysteine averts the toxicity How does it do? It will prevent the binding of NAPK to hepatic macromolecules. When when we were understanding the whole metabolism, or how paracetamol overdose causes hepatotoxicity, we have read that it will eliminate, or rather it will saturate sulfonation and glucuronidation process, and it will deplete the glutathione reserves in the liver, which is why the NAPK now gets like bound to hepatic macromolecules, which will cause hepatic injury, correct? So what N-acetylcysteine does is that it will prevent the binding of NAPK to these hepatic macromolecules, and hence it will avoid the development of hepatic injury. So it acts as glutathione or a sulfate precursor or as a substitute, and it will directly reduce NAPK back to acetaminophen. So this is how N-acetylcysteine works, and it still remains the mainstay for both prevention and treatment of acetaminophen toxicity. So if a patient presents to the ER and you have a strong suspicion of paracetamol overdose, the first thing you do is GI decontamination with early administration of activated charcoal. And once charcoal is given either orally or through NG tube, we uh, uh, give the antidote, that is acetaminophen toxicity. We give N-acetylcysteine to prevent the acetaminophen toxicity. Now, in established acetaminophen toxicity, that is post 24 hours of ingestion, it will diminish hepatic necrosis by acting as an antioxidant. It will decrease the neutrophil infiltration. It will improve the microcirculatory blood flow, and it will also increase the tissue oxygen delivery and extraction. So in early acetaminophen toxicity, that is within less than 8 hours, it will prevent NAPK from binding to hepatic macromolecules. But once the acetaminophen toxicity has been established, that is post-ingestion, 24 hours post-ingestion, it will have various mechanisms by which it will prevent further toxicity by acting as an antioxidant, and by various other mechanisms like I've just mentioned. So, which is why N-acetylcysteine is the mainstay for both prevention and for treatment. Less than 8 hours, it will prevent binding, and more than 24 hours, it will act as an antioxidant. It will decrease the inflammation or hepatic injury which has already been caused because of acetaminophen overdose. Now, if it is acetylcysteine is given within 8 hours of an acute acetaminophen ingestion, it is nearly 100% effective in preventing hepatotoxicity. It is that effective. Now, the longer uh, you take to initiate this therapy, and if it is gone beyond 8 hours, you will have more risk of hepatotoxicity. And the point that needs to be noted here is that it is both safe and also efficacious during pregnancy. So without further delay, N-acetyl ingestion or N-acetyl administration has to be uh, done. Now, there are two ways by which N-acetylcysteine can be given. One is a 20-hour protocol, which is wherein we give N-acetylcysteine through IV, and then there is a 72-hour protocol wherein N-acetylcysteine is given orally. Now, the standard regimen is to give IV, so that is a 20-hour protocol, which is what we follow, wherein the first or we give 150 milligram per kg loading dose, which is given over a span of 15 minutes to 1 hour, and now that is followed by first maintenance of 50 milligram per kg, which is infused over 4 hours, and then followed by a second maintenance dose of 100 milligram per kg, which is infused over 16 hours. So basically 20-hour protocol is IV and N-acetylcysteine administration, wherein 20 hours is broken into 3 different sets of hours. First hour, then first hour is basically the loading dose. It's given over a span of 15 minutes to 1 hour. That is the loading dose of 150 milligram per kg. And then 20 hours is broken into 4 hours and 16 hours, wherein for first 4 hours you give a maintenance dose of 50 milligram per kg, and then for the next 16 hours you give 100 milligram per kg. So 150 milligram loading dose, then 50, then 100 milligram per kg, and it is infused over 4 hours and 16 hours respectively. Now IV N-acetylcysteine is commercially available as a 20% solution and will require dilution to a 2% solution for infusion into a peripheral vein. Otherwise, it acts as an irritant. So both 5% dextrose in water and half NS can be used as a diluent. In here is the dosing regimen of N-acetylcysteine, which can be given orally or as an IV drug. IV drug, both you'll have, adult dosing and pediatric dosing, that is less than 40 kg of weight. Now, oral, you give a loading dose of 140 milligram per kg and 70 milligram per kg every 4 hours for 17 doses is what is given as a maintenance dose. So this is a 72-hour protocol. 140 milligram per kg is given as a loading dose. Now this is followed by the maintenance dose, that is 70 milligram per kg, which is given every 4 hours and 17 such doses is given. Now this is available as 10% and 20% solutions, and we dilute it to 5% solution. Similarly, IV dosing, like we discussed earlier, will be available as 20% solution, and we dilute it as 2% solution when we'll have to administer through peripheral veins. And then if it is less than 40 kg, you'll have 150 milligram per kg, which is infused over 15 minutes to 1 hour, and then you have 50 milligram per kg, which is infused over 4 hours, and then it is followed by 100 milligram per kg, and this is infused over a span of 16 hours. Both, what we need to know is that the dosing protocols is 20 hours for IV administration and 72-hour protocol is followed for oral administration. Loading dose for oral is 140 milligram per kg. For IV, it is 150 milligram per kg, which is infused over a span of 15 to 60 minutes. The treatment of paracetamol overdose is very simple, and it all depends on when the patient is presented to us post ingestion. Now, this can be studied by looking at 3 different time frames. One, when the patient is presented to us within less than 4 hours post ingestion. Our second, in the window period, that is the 20-hour window period between 4 hours to 24 hours post ingestion, and the last time frame is when the time of ingestion is not known or more than 24 hours have lapsed after or from ingestion. So when we look into those set of people who have presented to us within 4 hours of ingestion, the first treatment would be GI decontamination, wherein there is early administration of activated charcoal, either orally or through nasogastric tube. And then we send the sample for toxicology to check for the toxicity levels in the body, that is 4 hours post ingestion. Then the next step depends on when we are going to get the results. If we were to get to know about the level of acetaminophen in the body within 8 hours, then we will plot the measured acetaminophen concentration on the Rumack-Matthew nomogram, and if it were to be toxic, we will treat with N-acetylcysteine. But if the toxicity levels are not met, or it's not high enough to cause toxicity, then we just symptomatically manage the patient with whatever clinical features the patient has presented with. Now, let's just say if we were not to know when the patient, or if we were not to, or if the acetaminophen concentration was is to be available to us after 8 hours, then we will give the first dose of N-acetylcysteine within 8 hours, and then whenever we get the report or whenever we get to know the levels of acetaminophen in the body, then we will plot it on the nomogram, and depending on that, we will give N-acetyl. We will further continue the management with N-acetylcysteine if it is toxic, or we will stop the drug, that is N-acetylcysteine, if at all the levels are not toxic enough. And if the patient is presented between 4 and 24 hours from ingestion, then first thing we do is send the samples, and then accordingly, whenever we get the reports, if at all it is less than 8 hours, then we plot a nomogram. If it is more than 8 hours, if it's going to take more than 8 hours, then we don't really wait for the report. We give the first dose of N-acetylcysteine, and then whenever we get to know the concentration levels, then we will plot it on the nomogram and we will go on accordingly. Now, the third frame are those set of people who present to us with an unknown time of ingestion, or in those patients who have presented to us after one day of ingestion. In those people, then there's no point. In those people, we will go ahead with GI decontamination, because we don't know when the patient has ingested, and then we will send for toxicology lab to check for the paracetamol levels in the body. We check for all lab investigations, and we also give first dose of N-acetylcysteine. We basically do everything. We do GI decontamination. We also send for labs to check the acetaminophen concentration in the body, and we also give the first dose of N-acetylcysteine. Now, N-acetylcysteine in the body, if it is more than 10 microgram per ml, that is the therapeutic um, um, range, that is, or if the SGOT, SGPT are deranged, increased, then we continue N-acetylcysteine treatment, and if not, then we just provide symptomatic management. But if at all LFTs are deranged, or if that is, if SGOT, SGPT is deranged, and if pH falls less than 7.3, that is metabolic acidosis is seen, or if coagulopathy is seen with PT being more than 100, or if renal failure has set in, that is complications of paracetamol toxicity with creatinine being more than 3.3, or if patient has altered mental status, that is has gone into encephalopathy, then we refer the patient to liver transplant unit for liver transplantation. Now, to sum it up, less than 4 hours, we do GI decontamination. Then we send the samples to check for the acetaminophen concentration in the body 4 hours post ingestion. And if the labs were to be available to us, or the level was to be available to us within 8 hours, then we will plot it on the nomogram. If it crosses the toxicity level, we will give the N-acetylcysteine treatment. If it is not, then we will only symptomatically manage. But if the patient comes post 4 hours of ingestion, then we won't delay much time with the whole GI decontamination. We will just straight away send for paracetamol levels to measure the acetaminophen concentration in the body, and then we'll follow the same algorithm. But if the ingestion time is not known, then we will do everything. That is, we will decontaminate, GI decontamination is done, and then we will send for all lab investigations, including LFTs, and we also send for acetaminophen concentration samples to check for the concentration, and also we give first dose of N-acetylcysteine. Now, if that is more than 10 microgram per ml, or if we see abnormal LFTs, then we will continue treatment with N-acetylcysteine. Otherwise, we'll only symptomatically manage. But if the hepatotoxicity has blown up, like if all complications have set in, wherein metabolic acidosis is seen with pH being less than 7.3, or coagulopathy or encephalopathy has set in, then we will refer the patient for liver transplant. There is something called as King's College criteria, and this is to be used to know when the patient has to be referred to liver transplant unit. Now, it comprises of two major entities. One, when the patient has ended up with acute liver failure due to acetaminophen, and the second entity is non-acetaminophen induced acute liver failure. So for now, we'll concentrate on this entity, which is causing acute liver failure due to paracetamol poisoning. So in this, we will refer the patient to liver transplant unit if the pH has dropped to less than 7.3 despite our fluid resuscitation. So patient has landed up with metabolic acidosis and it is refractory. It's not been corrected with fluid resuscitation. Either this, or patient has to end up with has to end up in coagulopathy with PT being more than 100 seconds, INR being more than 6.5, or the patient should end up in renal failure with serum creatinine being more than 3.4 milligram per deciliter, or the patient should end up in grade 3 to 4 hepatic NCAF. So either it is refractory or metabolic acidosis which is not being corrected despite fluid resuscitation, or the patient should end up in coagulopathy, renal failure, and encephalopathy for the patient to be referred to liver transplant unit for liver transplantation. Now, moving on to the last part, that is disposition and follow-up. This is to know that when do we stop the infusion of N-acetylcysteine treatment, and when can we safely discharge the patient. Now, for this, what do we do is once we have finished the protocol of N-acetylcysteine therapy, that is either a 72-hour oral protocol or 20-hour IV protocol, then we will recheck the serum acetaminophen and transaminase levels in the body, and we will continue the infusion of N-acetylcysteine at the rate of 6.25 milligram per kg per hour, and we will look at the concentration of serum acetaminophen if it is undetectable or if it is less than 10 microgram per ml, and if transaminase levels are rapidly decreasing or if they have normalized, we can safely stop N-acetyl cysteine therapy and we can discharge the patient. Now, talking about those people who are not prone or who are not at risk for developing acetaminophen induced hepatotoxicity, those people will be observed in the ER for a period of 4 to 6 hours just to exclude any potential toxic co-ingestants that the patient could have taken before discharging the patient safely. And for those patients who have deliberately tried to harm themselves by paracetamol overdose, for those patients, psychiatric evaluation is needed. So let's know about what the prognostic indicators as to what will tell us that the patients who have taken paracetamol overdose will end up dead. There are certain indicators which are associated with highest risk of mortality from acetaminophen toxicity, or those who will end up with fulminant hepatic failure, and those indicators include metabolic acidosis when pH is dropped to less than 7.3. Mind you, this is a single indicator to refer the patient to liver transplant unit if acidosis has not been corrected despite fluid resuscitation. Then if the patient has ended up with coagulopathy with PT being more than 100 seconds or INR being more than 6.5, the patient has landed up with renal failure with serum creatinine being more than 3.3 milligram per deciliter, or if the patient has slipped into encephalopathy of grade 3 to 4, or if Apache score is more than 15, or if the patient consistently has elevated serum lactate of more than 26 milligram per deciliter or more than 3 millimole per liter despite fluid resuscitation, or if the patient has hyperphosphatemia of phosphate levels being more than 3.71 milligram per deciliter or more than 1.2 millimole per liter on the second day after ingestion. These are the indicators which will let us know that the patient has a high risk of dying. So this sums up paracetamol poisoning. Thank you.